Hello, my name is Hilda Reyes Salvador, and I will be presenting a case report labeled Parvo-provoked predicament, a perplexing ANCA-associated vasculitis progression. ANCA stands for anti-neutrophil cytoplasmic antibody, and it is commonly implicated in vasculitis. Vasculitis is an inflammatory disorder affecting the small vessels throughout the body, resulting in vascular discretion and tissue necrosis of multiple organs. This typically develops after activation of neutrophils by an infectious source causing lysis of endothelial cells and exposure to T and B cells, leading to a response that causes loss of immunological tolerance. It can present with an extensively varied symptomatology and renal manifestations, resulting in partial immune crescentic glomerulonephritis patterns on immunofluorescence. Parvovirus is an ubiquitous small single-cell DNA virus that is implicated in a variety of clinical syndromes, especially in immunocompetent adult hosts. Diagnosis is mainly through development of IgM that appear within 7 to 10 days after infection. Parvovirus can cause autoimmunity through direct cytotoxicity and humoral immunity after lysis of endothelial cells, triggering an autoimmune response. In this case, the patient was a 38-year-old male that presented initially to the emergency department for abdominal pain, weight loss of 20 pounds, arthralgia, mononeuritis multiplex, and a fever. He was initially misdiagnosed with pyelonephritis, leading to an empiric antibiotic treatment. However, he developed worsening symptoms with shortness of breath, indicating a greater disease process. Immunological workup revealed positivity to parvovirus B19 IgM, c-ANCA antibodies, and anti-PR3 antibody. This led to performance of a renal biopsy that showed typical histopathology, such as segmental fibroid necrosis of the tuft, segmental cellular crescents, arteritis, and IgM deposits on immunofluorescence. This led to the diagnosis and beginning of treatment with high-dose IV corticosteroids and rituximab. Patient improved rapidly and was able to be discharged on a taper of oral low-dose glucocorticoids, avocapan, and prophylactic Bactrim. This case showcased the diverse presentations that both parvovirus and ANCA-associated vasculitis can present with. Although parvovirus has been implicated in transient ANCA positivity, it typically does not cause vasculitis symptoms. It has been implicated in development of renal compromise and autoimmunity. This case presented with typical symptoms of both MPA and GPA, such as the renal compromise, the pulmonary compromise, and the gastrointestinal manifestations. Although the ANCA positivity and the clinical symptoms were enough to diagnose a patient, biopsy was performed due to the ambiguous presentation, and it remains the gold standard for patients such as this. Treatment is especially important in this patient in order to prevent further damage from the autoimmunity and development of end organ failure. Induction treatment is usually indicated with both IV methylprednisolone and a daily oral glucocorticoid taper. It is also suggested to begin treatment with cyclophosphamide or rituximab, and both have shown equivalence. Avocapan is a new FDA-approved medication that has been demonstrated to significantly reduce the need for glucocorticoid exposure, leading to improvements in quality of life. After induction treatment, it is recommended to begin maintenance therapy with rituximab or low-dose glucocorticoids with azathioprine. After diagnosis, monitoring for AVA relapses can remain a controversial topic. Multiple studies have recommended that trending for a rise in ANCA antibodies can be used as an early sign of impending relapse. In conclusion, this case demonstrates the importance of maintaining a broad differential and a high index of suspicion, especially in diagnosis such as this, where early diagnosis is crucial to the prevention of complications.